Thank you for joining us. I'm your host, Dr. J. Feldstein, and today we're talking with Dr. Ken Veit, Provost and Senior Vice President for Academic Affairs at PCOM. An alumnus of PCOM's class of 1976, Dr. Veit has been shaping the college's mission for more than 4 decades. He joined the faculty in 1980 and went on to serve as Senior Vice President and Dean of Academic Affairs for 30 years, the longest deanship in PCOM history. In 2009, he took on the role of provost, continued to guide academic innovation and institutional growth. Even with his many leadership roles, Dr. Veit has always stayed connected to patient care through his work as a professor in PCOM's Department of Family Medicine and as a physician at the college's healthcare centers. Before joining PCOM, he served as Chief Medical Officer for Region 3 of the U.S. Public Health Service and practiced in rural Pennsylvania through the National Health Service Corps, demonstrating his long-standing passion for community health. Today, we'll discuss the future of primary care and how future physicians can prepare to meet new challenges and opportunities in the field. Welcome, Ken, and you and I have talked about this. I've been really looking forward to this podcast because we talk about this every day.
Absolutely. Thank you, Jay.
So this is a real treat. So, you and I, we talk about new primary care models like direct primary care and concierge care and how they're transforming the patient experience. Can you explain these models and how they're changing the primary care landscape?
I'm not a total expert in some of these new models, but I know enough to have a discussion with our students about them. Certainly, concierge medicine has been around for a while in various models. It is essentially a way a patient will pay a subscription fee to a practice in turn for that practice to minimize the number of patients that provider will absolutely have an obligation to, with the expectation that there'll be more access, more care to that subscription. And it's a way to basically take away some of the burdens of the volume of primary care expectations and responsibilities. Now, that model can work as a mom and pop shop, or many times it can be purchased as a franchise, and they help you through that model. And many of my friends have taken that model recently, and it's interesting because when I talk to them, they are very much an advocate for this model. But I asked them a very simple question because they said, my life is so much better. I'm taking better care of my patients. I don't feel as frazzled at the end of the day because I can concentrate on a fewer number of patients. And I asked this person a simple question. When you basically made the offer to purchase a subscription, for those patients who did not have the money to buy a subscription, what happened to those patients? And she looked at me with a sort of sad eyes and said, I have no idea, Ken. So while she closed down her practice and made her practice model work better for her economically and patient care wise, there was a loss of access for people who could not afford the subscription. So again, it goes to the fact is that's one model. It seems to be working for the people who can afford it, and it seems to be working for the doctors who go in that direction. But there is a definite downside of availability for people to buy that subscription.
Yeah, I think that adds to the health equity issue.
Yeah, absolutely.
And one of the things that drives me crazy is all the services that are offered by concierge medicine. That's what family doctors used to do 15, right. 20 years ago. That was just part of their practice. You didn't have to pay extra for that.
It's being the great family doctor you want to be.
Right. But making people pay extra.
Exactly. But at the same time, that only, has access to the people who are ability to pay. And the rest of the people are certainly out of luck and have to find another primary care doctor.
The reason that happens is because primary care is underpaid. Okay. If primary care, specifically family medicine and general internal medicine, were compensated appropriately by the insurers, people wouldn't have to pay extra for this care.
Well, that lends me to a question to you as an ex-insurance chief who knows this other side of the business so well. When you, as a company, made a decision on how to allocate your resources, you couldn't get that argument in front of your bosses and everything else because clearly primary care reimbursement is at the mercy of third-party payments. And if third party decides that primary care is worth X and this is worth X plus Y, the payment streams don't change.
No, I couldn't. That's why I came back.
Oh, that's okay. That's the answer, Jay, is you couldn't make the
They
change.
couldn't make the change. I mean, the pyramid needs to be inverted. Right now, primary care is at the base of the pyramid in terms of payment. And then you go all the way up to the top, it's hospitals and specialists. Where the reality is primary care feeds that. And if you really want to get value out of primary care, the preventing chronic disease, treating it appropriately so people don't end up in the ER and end up getting admitted, you got to pay them more. And I always said back in the US healthcare days that you and I remember when capitation was $10 for a member, they didn't go far enough. It should have been $100 a member. And the primary care physician should have figured out who am I going to pay as a specialist and what hospital am I going to put my patients in? And they become the financial gatekeeper, not just the referral gatekeeper. But obviously, nobody bought into that idea either.
For many different reasons. But again, I think the idealistic capitation model was very attractive 40 years ago, 35 years ago, and still are. But now we're doing something a little bit different because direct primary care is a little bit different than concierge medicine.
Right.
And that has a little bit more of that capitation into it. Now, in concierge medicine, they get the subscription, but you also use their insurance in addition to the subscription benefits. Direct primary care is a little bit different because it's either a company or an insurance or something will buy a capitated price for primary care. And then you are living in a more capitated world, taking care of X amount of patients, not billing anything, because the burden of primary care to get reimbursed is a huge cost structure, and the complexity of getting paid. Anybody into primary care says it's a huge cost. So direct primary care is a little bit different because a company XYZ says, look, I am going to give medical insurance to my beneficiaries, but I know primary care is so important. I will carve out primary care and give a significant amount to a primary care practice to do all the great things you just said on a capitated basis. Now, hopefully they pay them enough to do all that good stuff. So there's a spin effect of using a capitated model in 2026 that's a little bit different than back in the US health days when we first got into it. I don't know whether we're ever going to find the perfect model, but I think you're absolutely right, Jay. The core of care, and we hear it all the time, is where's my primary care physicians? And the difficulty of recruiting primary care is very much a outcome of how we pay people. I mean, it's relatively simple. You get what you pay for. And our fragmented healthcare delivery system of payments are so gerrymandered. Anybody can see why primary care is struggling right now because it's not being valued. Now, some of these new models, maybe there's other new models I've seen. How does the independent primary care doctor stay alive? And we were just talking to one of our alumni recently, and they put together like 85 independent practices to have some leverage. And so they basically have remained independent, but they basically created commonalities. They have a common lab, they have a common billing system, but they are still independent practices that make what they take home every day. So if one of those practices wants to work very hard, their economic base will reflect that. If another practice says, look, I really don't need that salary and I reduce my hours, that's what they get. So it's not socialism, it's still an individual practice. Now, whether that can be coordinated, it's a difficult thing to coordinate. It's in central Pennsylvania, a little bit different demographics, but it has been successful as an independent primary care practice to have negotiation ability with third-party payments, getting more engaged with the problems and share the cost of running a primary care practice in a independent world, as opposed to working for a mega system.
I think one of the other challenges that drives me nuts as an advocate for primary care is to see it getting fragmented in terms of offerings to patients online. Whether it started out being able to get your Viagra script online through telemedicine, and now the GLP-1s have created this entire cottage industry of weight loss doctors online, which really, at the end of the day, should be the purview of primary care. You don't see them starting out blood pressure online primary care. right? Because that requires continuity. And in fact, I wrote an editorial because somebody published an article in the Wall Street Journal about how successful these online companies are with GLP-1 prescribing and how they're signing up thousands of patients. And I said, who's the patient going to call at 3 o'clock in the morning when they have an attack of pancreatitis as a side effect of this? They're not calling the 1-800 teledoc number. They're going to call their family doctor who's going to have no idea they're even on the GLP-1.
Capitalism predominates our country. I mean, so where there's a dollar to be made, somebody's going to find a way to make a dollar. And it's the reality. And if it's not GLP-1 pharmaceutical, it's some other mechanism. I think the primary care doctors go crazy with that because clearly we are still the continuity, the longevity. I mean, what we add to the equation, which these companies do not, is knowing the patient comprehensively through a long history of taking care of that patient. And so when our patients start branching into these other events we might or might not have knowledge about, it sort of defeats the whole purpose. And when I get the call, we might not even know they're buying this drug at 2 o'clock in the morning where there's a complication, because you're right, the complication is going to end up on our lap, which is another reason why it's so frustrating today to be a primary care doctor, because there's somebody else taking bits and pieces of your continuity and comprehensiveness.
I feel like primary care is a giant whale, and these sharks are taking bites.
Oh, you're right, Jay.
out of
You're
it.
right. I mean, and again, until the short
Until the whale's gone, right?
It's gone until you.
Well, that's what I think. That's what that's what we're trying to prevent.
Right.
We're
And
trying to save the whale here.
I don't know whether we can stop the feeding, because the feeding is driven by making dollars. And if there's a dollar to be made, I think sharks will continue to bite. And again, you have to find sort of creative solutions to try to minimize that bite. And I think there are certain opportunities, but I don't think there's a perfect opportunity. I don't think there's one thing anybody can do. And I'm just, so happy to, that we continue to graduate so many people who are still interested in primary care. And I think that's an attribute that PCOM brings to the table, is that in spite of all these pressures, we still have 60% of our graduates will choose primary care disciplines. And I think they go in with open eyes too, recognizing these challenges are there and are willing to take on these challenges, which makes me even more thankful for our.
Well, I mean, that's our culture, and you, quite frankly, helped to build that culture over the last 40 and 50 years.
Well,
Continue it. And we all came into it,
Yeah.
and we're just continuing that culture. And that's the type of student I think we attract
Yeah.
to a large extent. It's funny because you and I both have and had elderly parents and have experienced fragmented care in the hospital setting, which drove both of us nuts and still does. In the fact that the day of the family doctor being the quarterback in the hospital and bringing everybody together and actually, being the continuity contact point, it's gone. It's gone. It's gone. And I don't know if we can ever get it back.
There's no general contractor who's controlling the
Right.
building of the house or taking care of the patient. We've all experienced that. And, the general interns used to also be that person who would go in the hospital and make rounds.
And
on
even
their
the family
patients.
doctor would refer to that general internist
Right.
that would take care of the
Right.
patient in the hospital. And there was a great relationship, whether it was in the doctor's lounge or making rounds together or just a courtesy phone call. And that's gone because somehow the EMR is now the panacea for communication and connectivity, and it doesn't work.
And when you and I went through training, there was no such thing as a hospitalist.
Right.
So now you have shift working mentality at the hospitalist level, who allegedly is supposed to take that role of the coordinator of hospital-based care. But at 6 o'clock, I leave and hand my cards off to someone else, and I'll see you 4 days later, So it is many reasons, but it still goes back to the economics of running hospitals. I remember why family doctors were told don't come in anymore, because the regulatory oversight of the hospitals and the bureaucracy of hospitals got so complex that you, as a doctor who had 2 or 3 patients, it wasn't worth your time, effort, and you just screwed up the discharge. Therefore, the CEO of the hospital says, I got to get this patient out because of DRGs and other things. I got to get this patient out by 11 o'clock, but I can't make rounds at 3 p.m. Well, guess what? That efficiency, me being the primary care coordinator of that patient's care, wasn't working for the CEO of the hospital. So that's, I mean, you can always explain why these things are moving in this direction. The question is, how do you know, continue to keep the patient in the center? And I think that's one of the things that I think family medicine and primary care still says, okay, I got all these forces that are causing me not to be able to do my job well, whether it's the EMR, whether it's third-party payments, or it's specialists that are fragmented. I think the role of the family doctor is more important now than ever because of just what we talked about. Maybe we'll never go back to where we were 25, 30 years ago, but there's still things you can do to try to coordinate care. And I think it starts off with caring. I mean, I hate to say it, but caring about the patient is still, I think, what I'm really impressed that our students do still care, especially if they choose primary care. Um, Now they're going to be attacked by all these various mechanisms and all these, people trying to take a bite out of their business. But again, you're right. The picture at the end of the day, the patient that you know for 30 years and the people who are doing family medicine or primary care know that you know more about that 30-year relationship than anybody else.
Or that any EMR will ever reflect.
Absolutely. And the EMR is another evolutionary problem, which I hope it's evolutionary to something. When we started that 20 years ago, it's going to solve all the problems. Well, it's created most of the problems.
Well, it's created the administrative burden practice.
And the hope is that as we itinerate with more IT solutions, whether it's like, an AI help, which I think is going to be a while to you really get to fine tune it, but it's certainly the EMR of today has got to evolve. It's got to evolve, and it's something that makes the experience of going to a primary care office less stressful for both this patient and the doctor and the staff. Now, cross my fingers that, somebody's going to have a bright idea of how to move this. But it's, I guess I got to be optimistic. We can talk about all the problems, Jane. We know them all. But I still love the fact that so many of our students are willing to accept the problems, be challenged by the problems, and willing to have develop that long-term relationship with a patient that is, I think, at the core of what we hope to achieve when we graduate a student. And when they choose primary care, I think they've accepted all these challenges. They don't know particularly how they're going to deal with them, but I think they are not going into primary care blind. I think they know that, and for many, many reasons, they are accepting these type of challenges, and that makes me feel good about the type of students who come to PCOM, who graduate from PCOM, and are trying their best to deal with all these issues.
So, we talked a lot about AI and what that can, especially the ambient AI that can take away the documentation challenge and burden, the administrative burden. Some of these programs they'll take the medical record, they'll convert it into a bill, they'll send the bill out. The two AIs, the insurer's AI and the billing company AI, will battle it out to get the claim paid. Hopefully, will relieve a tremendous amount of the administrative burden, which I think will be a positive. Whether that happens or not remains to be seen. But I think you're right. At the end of the day, you gotta care about the patient you're taking care of.
Absolutely.
And, my old ER mentor would always say, if you take care of the patient, everything else takes care of itself.
Mm-hmm.
But it's a challenge to our kids.
Absolutely.
And I think it's why you and I get up every day and come to work, because we enjoy it and they keep us going. But so many of them get into a hospital system. Close to 60% of all the practices now are owned by hospital systems.
Right.
So it's going to take a unique person to want to go out on their own.
Yeah. Or
today.
The systems will ultimately realize the value of primary care. And it's funny because I have the opportunity of talking to students as fourth-year students, which I think is really when they're mature enough and have been around the block enough to try to deal with some of these intricate, involvements. I asked them a question in the fourth year, and I said, where do you come from? And half of them come from Western PA, some come from up the Geisinger area. I said, is it good or bad for society to have a mega system that employs all the doctors also being an insurance product? And the kids are funny because their immediate reaction is no, no, no. And then I said, well, think about it and let's talk about it, because I usually end up with, if I get the students thinking right, sort of the more right-wing students fight against the left-wing students. And it's funny because there are maybe some opportunities to have everything under one roof, but that might be a continuum to national health insurance. Ultimately, where does these mega systems go to? Because if you're the insurance company, and Jay, you know this better, you have to you have to figure how do you serve a bigger number,
Right.
not just what the hospital and what's good for the hospital. So as Geisinger and UPMC all have insurance products now, and Jeff has an insurance product, do you look at delivery care a bit differently than you would if you're just worrying about your hospital?
Well, I think they have to, and the hospitals have to, because 80 to 85% of the care now is not in the hospital. It's outpatient. And the irony, this is the other thing that you want to talk about a lot, is then why is 90% of the training in the hospital?
Historical,
It-
historical, and it's more controllable too.
True.
It's more consolidated. It's more condensed, and it's not necessarily. And again, we get all the complaints. Well, your intern wasn't trained well enough to be an intern. But I asked them when they finish their residency, is this resident ready to go out and practice? And they say, oh, probably not. So we do know the failures of the system, but we don't really know how to break the historical reimbursement. It goes right back to reimbursement. I mean,
Follow the money.
follow the money, because if CMS is buying this product and not buying a more diverse educational environment, what do you expect? You can't, follow the money. And I don't think CMS is ever going to say, okay, we're going to give the money to a medical school,
No.
to look at the best way.
It's a $3 trillion industry that is very complicated, interrelated, and it's a system that's almost impossible
To
to
change.
change.
And so we're stuck with it, and we're stuck with a training environment, learning environment that is very stuck in the 25-year-old model. And it's tough to turn that machine around. Now, maybe in a bigger mega system, and of course the students all hate the mega system. I'll never work for Geisinger, I'll never work for UPMC. But if you're the insurance responsible person to take care of a client, you might have more leverage over what you need coming out of that mega system training program. And I make the argument with the students, because they always come to me and say, why aren't there more dermatology spots? Why are there not more ophthalmology spots? And we go back to follow the money. If you're a CEO of the hospital, you want to take care of your ICUs, you want surgeons to operate 24/7, you want anesthesiologists to cover the OR, because that's where the money is. But if you're an insurance company, you need to look at the workforce needs differently. Maybe they need 3 dermatologists to take care of that population. They might not need 4. Hospital needs none. Do you understand what I'm saying?
Yeah, for sure.
The hospital needs no
Well, that's why
dermatologist.
those residencies are so limited.
Right, because the
The
hospital
hospitals won't
doesn't
pay
need
for
money.
it.
But an insurance company needs X amount of
Access.
and they might look at the workforce needs totally different
Well-
than a hospital does.
Well, again, not that we haven't had this conversation, is I see in the future where you will start to see private entities, whether it be hospital systems, private equity, starting to pay for GME that they're going to need.
Yeah.
And outside the CMS system, people don't understand. ACGME is responsible for the residency accreditation, but CMS is responsible for paying the bill. But they're not related.
Right. And
So you can have your own accredited residency and be paid from a different
Absolutely.
entity. And I think you'll start to see that to address the issue that we just talked about.
Yeah, and looking at the workforce needs from a more global level, as opposed to just a hospital-based level that will push the dollars differently. So again, it's going to be exciting. I always challenge our students. I said, boy, you're along for the ride, guys. You're going to have so many things are going to change in the next 10 to 20 years. And be prepared to have resiliency, keep your eye on the ball, keep caring for your patients, because only if you care for your patients, that sort of goes a long ways. But again, I don't know what these things are going to do, but it's fascinating to watch this evolution of new students go into the workforce. And as we know, we've talked many times, they're a bit different. They obviously looking for more balance in their lives, which is not always bad. I mean, a lot of times we went through it and we didn't balance our lives well enough. And so they are much more concerned about finding that delicate balance. And at the same time, I think they're idealistic, that they really want to take good care of people and don't lose the idealism.
Well, I think on that note, Ken, I want to thank you for joining us today.
We could talk
I know
for another
for
hour.
a couple hours.
Hour or so.
You know.
This is an incredible topic. I didn't even get to half the things I was going
I
to
know.
say, but maybe we can do
We'll
it
do it again.
again.
We'll do it again. But really, just want to thank you for your unwavering commitment to mentoring future physicians, especially in primary care, in an ever-changing industry. Your dedication to advancing patient-centered care continues to exemplify PCOM's mission, and we are grateful for your leadership, and I am grateful for your friendship. I'm Dr. J. Feldstein, and this has been PCOM Perspectives.